Done?
Yes, yes, ma'am, I'm sharing the screen.
Yeah.
Sajita, is it visible?
Yes, ma'am, it is visible.
Yeah.
You can
I start,
ma'am.
Sajita?
Yeah, ma'am,
Okay.
you can start.
Okay. Thank you. Ma'am, can I start?
Hello. Yeah, you can start, please. Yeah.
Yeah, thank you. Good morning, doctors. A warm welcome on behalf of Shield Healthcare. And good morning, Dr. Farah England, ma'am. Thank you very much for accepting our invitation. And it's my honor and privilege to introduce you. Ma'am is MD Internal Medicine, DFID in Diabetology, also PHFI in Diabetology, MCARD in Cardiology, and FICIC. Consultant Hiranandani Hospital, a Fortis Network Hospital, Navi Mumbai. Ma'am has over 3 decades of professional practicing experience. Ma'am believes in promoting health awareness and healthy lifestyle. Ma'am has published several papers regarding diabetes, renal disorders, ARF, immunomodulation, renal sepsis, kidney functions, and metabolism. And Ma'am has won the award of Silver Jubilee Memorial Prize for standing first in forensic medicine and toxicology. So with this, may I request Ma'am to deliver a lecture on management of hospitalized COVID patients. So over to you, Ma'am. Thank you very much.
Yeah. Thank you so much for your kind introduction for me. I'll just share my screen. 1 second, please.
Thank you, ma'am.
Thank you.
Yes, we can see your screen, ma'am.
Yeah. I'll just begin. Okay. So should I start now?
Yes, ma'am, please.
Yeah.
Thank you.
Yeah. So formal good morning to every one of you. And this is the pandemic going on. All the talks now are on COVID and nothing else but COVID. So also we are dealing with the COVID talk today. And as Dr. Prachi said, that I would be talking on the management of COVID-19. This is my very first slide, which shows an elephant being seen by how it is being described by blind men. So when the pandemic started, that was in December 2019, it was like being described by a blind man. It was a totally new virus to mankind. Nobody had any experience. There was no protocol, no guidelines. Slowly, the emergency use authorizations of experimental drugs and repurposed drugs were done. By around 3 to 4 months, when the pandemic started, we thought we were able to understand the disease better and were able to manage that better. But the second wave has proved us all wrong, and the second wave had caused so much of morbidity and mortality, and many of the drugs which were said to be good during the first wave had now stand as being not useful. So again we are back to square one, and it is again like a big huge elephant being described by blind men. So whatever they understand, they will describe it and treat it that way. Still, we are not very sure about the management of COVID. It keeps changing day in and day out, and is right, as rightly said, it is a very predictably unpredictable disease. So it all started in the Wuhan city in the Hubei province of China in December 2019, and hence named as COVID-19. It spread to China and then to the world over to become a pandemic. And our country, as with all over the world, was badly affected. In fact, in the second wave, our country had been the worst affected, and there were about 3.1 lakh deaths in our country, about 2.74, in fact 2.77 by day before yesterday, and good recovery too, but deaths as well. And in the second wave, more of a younger generation had succumbed to this problem. So, as I've just said, it started in the end of 2019 with where the cause of cluster of pneumonia was discovered in Wuhan, in Hubei province of China. And in February 2020, WHO has designated the disease as COVID-19, and it is transmitted from animals to man and then from man to man. So the novel coronavirus originated in some animals, and this coronavirus are there for decades. COVID-19 is a new virus amongst the coronavirus group, and it is usually transmitted through either snakes, hedgehogs, bats, masked civets, rhizomes, pangolins, and this time it was thought to be the snake. So, novel coronavirus are enveloped positive sense single stranded RNA viruses, which infect a wide variety of host species and are divided into different genera, namely the four genera like alpha, beta, gamma, and delta, based on their genomic structure. Only the alpha and the beta coronavirus infect mammals. And human coronavirus like 229E and L163 are responsible for like common cold in cow and belong to alpha coronavirus. We had SARS, we had MERS, and then SARS-CoV-2, which are classified to be as beta coronaviruses. Then the SARS, that was again a pandemic in 2003, which was primarily the URINTIT of mammals and birds that was infected. Then we had MERS, that is Middle East Respiratory Syndrome, which was again caused by another coronavirus, where it was very lethal actually. About 3 or 4 out of every 10 patients had died during the MERS pandemic. And then this is COVID-19. Now, COVID-19 virus, as I've said now, is a person to person transmission, mostly transmitted through respiratory droplets or close contact. Mean incubation period ranges from 1 to 14 days, mostly, maximum being 5 days. In 95% of cases, symptoms are within 12.5 days of contact, and one person is likely to infect 2.6 persons, and this 2.6 persons further infects another 2.6 person each, and that is how the transmission goes on in multiplications. So when you cough or sneeze, if you are infected, you are transmitting out viruses. Then those viruses, when they land up on surfaces, and if some other healthy person touch those surface, then and if they touch their eyes, nose, or mouth, which is the portal of entry of the virus, then they get infected. Close personal contact like touching or shaking hands can also transmit the disease. When it was first known to mankind, it was thought that respiratory droplets as well as contact transmission through fomites are both equally responsible, but over a period of time, WHO said that it is mostly respiratory transmission through droplets more than the fomites. So these are the symptoms when the person gets infected with COVID-19 virus. They can present with fever, which could be high fever above 100 degree. It may be with chills. There is a lot of myalgia, muscle aches, pains, headache. There can be cough, sore throat, and difficulty in breathing. There can be new loss of taste or smell, diarrhea, nausea, vomiting. All these are symptoms, but none of the symptom is pathognomonic for COVID. These symptoms can be found even in other viral illnesses or bacterial illnesses, but the loss of taste or smell, if it is new, if it was not there, then even if the RT-PCR is negative, it should be considered as COVID. It is said to be next to RT-PCR report. So incubation period, as I've said, can extend up to 27 days. Recovery time may be from 3 weeks to 6 weeks, but in some people it can go on for even up to 6 months to 1 year. The symptoms can linger on. And frequently reported signs and symptoms, as I said, the commonest, actually, if you see, about 70 to 80% of people are asymptomatic. They have no symptoms at all. They themselves are not aware that they are harboring the virus, that they are suffering from infection. And these are the ones who roam about freely in the society and infect other people. Then the commonest symptom is fever, which is seen in about 77 to 98% of people, followed by cough, that is 46 to 82%. Then myalgia, fatigue in about 50%, shortness of breath in about 3 to 31%, and the abdominal signs like vomiting, diarrhea, abdominal pain, and nausea, which is reported in 50% of cases. Sore throat, headache, cough with sputum production, and or hemoptysis are less common with hemoptysis actually, but sore throat is a common symptom, so also headache and cough. So now it's important to know different cases because these all can get admitted anytime and you have to follow them on from here onwards. So you can divide the cases into three types: the suspect case, the probable case, the confirmed case. What exactly is the suspect case? Now, a person who meets the clinical and epidemiological criteria, like they have acute onset of fever and cough, and acute onset of any three or more of following symptoms like fever, cough, general weakness, fatigue, headache, myalgia, sore throat, coryza, dyspnea, anorexia, nausea, vomiting, diarrhea, altered mental status. So, out of this, any three or more signs. And epidemiological criteria, which is not so much applicable these days. When it had come initially, we used to ask them history of travel and all. Now the world is asking them history of travel from India. So our country has gone low and is the culprit these days because maximum number of cases are in India now. So like epidemiological criteria is the one: residing or working in an area with high risk of transmission of virus in close residential setting, camps, humanitarian camps, then residing or traveling to with area with community transmission anytime within 14 days prior to symptom onset, then those who are healthcare workers working in healthcare facilities and hospitals and so on. So these are the suspects. Then the probable case is one where a patient who meets the clinical criteria above the ones which I had said and is also a contact of a probable or confirmed case or are linked to a COVID-19 cluster. So a suspect case with chest imaging showing findings suggestive of COVID-19 disease, or a person with recent onset of anosmia, as I've said, that is loss of smell is anosmia, or agusia, that is loss of taste and absence of any other identifiable cause. Because loss of smell you can get even in other problems like URIs, allergic issues and all. And then if there has been death which is not otherwise explained in an adult with respiratory distress preceding death and was a contact of probable or confirmed case or linked to a COVID-19 cluster, they are all labeled as probable cases. And then we have the confirmed case where a person with a positive nucleic acid amplification test, that is not, or including RT-PCR is one of it, or any other similar test which is approved by ICMR. And a person with a positive SARS-2 antigen test, because if the antigen is positive, then there is no need to proceed for RT-PCR. It is taken as a confirmed case. And when antigen comes negative, you definitely have to go for RT-PCR. And any asymptomatic person with a positive SARS-CoV-2 antigen who is contact of a probable or confirmed case, they are all taken as confirmed cases. And who are the persons who are at high risk, who needs to be monitored very closely? And in fact, if these group of people suffer from COVID, it is best to keep them in the hospital under close observation. So these are the people more than 60 years of age with cardiovascular disease, hypertension, coronary artery disease, those who are diabetics, those who are in immunocompromised state, those who have chronic lung, kidney or liver disease, those who have cerebrovascular diseases, and those who are obese. So clinical severity could be mild, moderate, or severe. Clinical presentation is like patients with uncomplicated upper respiratory tract infection may have only mild symptoms like fever, cough, sore throat, congestion, nasal congestion, malaise, and headache. These are the ones counted as mild cases. Now, anytime a mild case can turn to moderate to severe in no time. So you have to be watchful for these patients also, even if they are not admitted, because they can require admission anytime. And here the clinical parameters are: they are without shortness of breath or hypoxia. Their oxygen saturation is normal on room air. So these are managed either at home as per the home isolation guidelines, or if it is not possible for them to get isolated at home, then they can be managed at CCC, that is COVID care centers. Then we have the moderate ones where they have pneumonias, but there are no signs of severe disease. So these are adults with presence of clinical features of dyspnea and or hypoxia, fever, cough, but the SpO2 is less than 93 but more than 90 on room air, and respiratory rate is more or equal to 24 per minute. These cases fall in the moderate category, and these patients needs to be admitted in a dedicated COVID health center, that is DCHC. And then the severe ones are ones with severe pneumonias where the respiratory rate is more than 30. Now in moderate it is more than 24 but less than 30, but in severe it is more than 30 beats per minute. Severe respiratory distress where the oxygen saturation on room air is less than 90. These patients needs to be admitted in dedicated COVID health centers, that is DCH, not DCHC. And then we have the very severe ones, like those who come with ARDS or acute respiratory distress syndrome, where there is new or worsening respiratory symptoms within the 1 week of known clinical insult. Chest imaging, either X-ray or CT, will show bilateral opacities not fully explained by effusions, lobar or lung collapse or nodules. And the origin of pulmonary infiltrates is not fully explained by cardiac failure or fluid overload. They need objective assessment, even echocardiography, and to exclude the hydrostatic cause of infiltrates or edema to differentiate whether it is a lung cause or a otherwise cardiac cause. Then oxygenation impairment, depending on the degree of PaO2 to FiO2 ratio. The ARDS is categorized in three types, that is mild, moderate, and severe. The mild one is where the PaO2 to FiO2 ratio is less than 300 but more than 200. Moderate one is where it is less than 200 but more than 100. And the severe one is where PaO2 to FiO2 ratio is less than 100. These patients are managed in the ICU of a DCH, that is dedicated COVID hospital. Then sepsis also, it's an acute life-threatening organ dysfunction which is caused by dysregulated host response to suspected or proven infection. And the signs of sepsis here, because of organ dysfunction, includes altered mental status, the tachypnea, low oxygen saturation, reduced urine output, weak pulse, cold extremities, low blood pressure, and so on. And lab findings of coagulopathy, thrombocytopenia, acidosis, high lactate or high bilirubin. And these patients are also managed in the ICUs in DCH. And the septic shock again is a very serious condition where there is persistent hypotension in spite of volume resuscitation, and they require vasopressors to maintain the mean arterial pressure of more than 65, which is actually the best to maintain. And then serum lactate levels, which is more than 2 millimoles per liter. These patients also needs to be managed in the ICU. So there are different stages, as I've said, for this COVID-19. That is stage one. The first one was mild, moderate, severe, very serious. And this is another way to stage it. That is stage one, stage two, and stage three. Stage one is usually an early infection, which is a viral response phase. Usually complications do not happen in stage one. There are not many symptoms and signs in stage one. There may be mild constitutional symptoms like fever about 99.6 to 100 with some cough, diarrhea, headache. There may be lymphopenia, and the prothrombin time and D-dimer and LDH may be raised. This period is a relatively easy and safe period, but then progressing from here to the second phase, that is stage two, which is a pulmonary phase, where it is again classified into 2A and 2B, is where you have to concentrate most, observe the patient carefully, and manage the patients properly, because here in stage 2 and stage 3 is the host inflammatory response phase, where the patients can land up in cytokine storm and other complications. So here the patient will develop shortness of breath, there will be hypoxia, as I've said, PaO2 to FiO2 ratio may go less than 300. Here you will get abnormal chest imaging. So when the patient comes to you, if he's asymptomatic, don't unnecessarily hurry or push in for CT scan, because you may not find anything. CT score may come 0 in stage 1, and then you get relaxed, and then patient can get neglected or mismanaged. It is at stage 2. The best time to do the CT scan is from day 5 to day 10. So here you will get abnormal chest imaging and low normal procalcitonin level. Here, after that, there are chances of secondary bacterial infections happening. Otherwise, usually it is a viral illness, and stage 1, in the first week, usually there are no complications. And stage 3 is the one where patients become very serious, like they can go in ARDS, septic shock, cardiac failure, which I had just shown in my previous slides. And here the elevated inflammatory markers like CRP, LDH, IL-6, D-dimer, ferritin, these are all inflammatory markers, and even the cardiac markers may become deranged. So you have different potential therapies, like I will discuss it. This is an initial slide where they had mentioned remdesivir, chloroquine, hydroxychloroquine, convalescent plasma transfusions, and corticosteroids and other things. But then, as I've said, there are controversies all along, which we will discuss later. And I've already mentioned this. So lab investigations, once the RT-PCR is confirmed, it is a confirmed case if it's positive. Then you do the basic CBC, where in that you have to see for NLR ratio, that is the neutrophil to lymphocyte ratio. What is seen is there is lymphopenia, neutrophilia, and NLR ratio more than 3.5 is a worst prognostic criteria. Then liver function, kidney function has to be done at the baseline in an admitted patient, because in case you need to give antiviral therapy like remdesivir, the liver function and the kidney function has to be all right. Then coagulation profile, D-dimer fibrinogen is very important. Depending on that, you have to decide on the dose of low molecular weight heparin or anticoagulants. IL-6, CRP, ferritin, LDH, as I've said, they are the inflammatory markers. TROP-T, NT-proBNP, the cardiac markers. PCT, that is second week, usually we do to see for superadded bacterial infections. ECGs to see for QTCs, and X-ray chest and HRCT chest, and those indicated. So as I've just said, there's lymphopenia, NLR ratio less than 3 is good, more than 3.5 is not good. And this I've just explained already. So what do you see in the X-ray? X-ray, usually it is bilateral involvement, the posterior lobe involvement. It is bilateral lobar pneumonias and multiple patches seen. And this is the HRCT finding, where you can see the bilateral side and posterior involvement of the lobes. So initial CT patterns in COVID-19, it can present in various ways. There can be ground glass opacification, which is seen in 88% of cases. As I've said, usually there is bilateral involvement, that is in 88% of cases. Posterior distribution in 80%. It is multilobar involvement in 79% of patients, and peripheral distributions at 76, and consolidation in 32. So these DGOs, if they are bilateral, posterior, multilobar, it all points towards COVID infection. So depending on that, we grade, that is called as CORADS grade, where the level of suspicion of COVID-19 infection can be determined. So CORADS 1 is where it is a normal CT. CORADS 2, where there is low probabilities and abnormal consistent with infections other than COVID-19. CORAD 3 means it is indeterminate, means it's not clear whether it is COVID is present or not. CORAD 4, where there is high suspicion because of the abnormalities which is suspicious for COVID-19, which I've just said. CORAD 5 is very high probability. It is typical COVID-19 presentation, bilateral, posterior, multilobar. And CORAD 6 is when even the RT-PCR is positive. Now, RT-PCR may not be positive in 30% of patients, in spite of best of techniques and best of laboratories, because there are reasons to that, like there can be an agent issue, there can be a collection issue, there can be the issue of load, viral load, and so on. So it may not be positive in 30% of cases. And if you clinically still suspect it to be COVID, you may take the help of CT because it is very sensitive. And then other supportive, as I've said, tests are the COVID antigen test, that is IgG, IgM. So then coming to the management, we have the options for managing this COVID-19 admitted patients. We can give antivirals. Now, amongst the antivirals, what works best is remdesivir, because initially we had used lopinavir, ritonavir. Then later on, it was found that it is not that useful in either reducing the viral load, or it has no effect on mortality. Then favipiravir is also found to be useful only in mild cases, and that too if it is given in the first 3 days. Best effects we have seen are with remdesivir, and that too if it is given in the first 9 days, though it has been said to have no effect on the mortality, but it can reduce the symptoms and it can reduce the length of hospital stay. Then anticoagulation, which forms a very important part of management. Immunoboosters, there are again controversies to that, because zinc, now the cases of mucormycosis coming up, is controversial. Oxygen is a very important part. Steroids are important part, but has to be used judiciously. Serious patients may require ventilator. Then judicious fluid management is very important. Initially, we start with the crystalloids, and then not maintaining the blood pressure. In those cases, we start with vasopressors and immunomodulators also in the second week when the cytokine storm is there. So this is the joint actually recommendations from AIMS, ICMR, National Task Force COVID-19, Joint Monitoring Group, and from MHOFW, that is Ministry of Health and Family Welfare, Government of India, which everyone follows for the management. So this is a very busy slide. Actually, I don't know whether it's clearly visible to you or not. So I've made it a little easier for you in my next slide. I've taken each part differently, which I'll explain you accordingly. But then, as I've just said, that remdesivir is the only antiviral which is found to be effective, but does not have any effect on mortality. And we will come to it. So patients with suspected or confirmed mild COVID-19 are either isolated or they are isolated basically with the purpose of breaking the chain or suppressing the chain of transmission. So these are the patients. How you manage these mild cases is, because they are a source of infection, so they should be isolated at home. If there is a separate room with attached washroom for them, if they can monitor their own status, like monitoring their oxygen saturation, monitoring their temperature, they have to download the Arogya Setu app there, and they have to be in constant touch with their the doctor, the physician, and teleconsultation can be done with them, because these patients also can turn into moderate to serious patients anytime. If there is no separate room available in the house with attached washroom, or if they are not able to take care by themselves, they are not able to monitor themselves, then these patients should be kept in the CCCs. Then the management of the mild cases are like those under home isolation or CCC. As I've said, they should be encouraged to take more fluids. It's important to maintain hydration. Hydration will help to maintain circulation, because COVID-19 is actually a hypercoagulable state. With hydration, you can maintain your circulation. And symptomatic management for fever, like paracetamol. For cough, you can give antitussives. Monitor the temperature and oxygen saturation at least 2 to 4 times a day with the help of the pulse oximeter, and stay connected with the physician. And they have to seek immediate medical attention if they develop difficulty in breathing, or if the fever is lasting for more than 5 days, it is better to get them admitted. Or if they have comorbidities like age or cardiac or renal or other issues, then it is better to keep them in the hospital. Then management, again, for the mild cases, paracetamol for fever. If the fever is not coming down, or if the symptoms are not responding to paracetamol, you can use drugs like non-steroidal anti-inflammatory drugs like NSAIDs or naproxen. Now, ivermectin, again, there is a controversy here. Initially, it was said to be a very good drug, said to be useful along with doxycycline and helping in viral clearance in 24 hours. So it was given on empty stomach once a day for 3 to 5 days. But some still say that it's a good drug. There are some papers published, but then ICMR also says that it has no effect on mortality or symptoms or viral load clearance. Anyways, this drug anyways has to be avoided in pregnant and lactating ladies. Hydroxychloroquine was also supposed to be a hero initially, but then now they say even hydroxychloroquine is not useful. Initially, we had been using that for prophylaxis. All the doctors must have taken the drug initially, and even for treatment of mild cases in the dose of 400 milligram 2 times. And as prophylaxis, we used to take it once a week. But now they say that it is again a drug which is found to be not useful, but it is still there in the guidelines. In the latest guidelines, even ivermectin, doxycycline, hydroxychloroquine is all mentioned actually. Then another good drug is inhalational budesonide, which is given in the dose of 800 microgram twice daily for 5 to 7 days. It is a steroid basically if the symptoms are persistent beyond 5 days of the onset. Then systemic oral steroids are not indicated in mild disease. Actually, there is no role of steroids in the first 7 days. And later on, if the fever is persistent or if there is breathlessness, if the oxygen saturation is falling, then you can use steroid. Steroids should be used judiciously and unnecessarily don't prolong the patients on steroids. So, in case of falling oxygen saturation or shortness of breath, you have to seek immediate consultation with the treating physician and hospitalize the patient. Then, coming to the management of moderate cases, now patients with suspected or confirmed moderate COVID 19 can present to an emergency unit or a primary care department, which or be encountered during even community surveillance activities. So the defining clinical assessment parameters are those with a respiratory rate of more than 24, as I've said, and oxygen saturation of less than 93 but more than 90. They are labeled as moderate cases and they should be admitted to DCHC. And then the further workup should be done, like those patients need to be closely monitored for their vital parameters, temperature, pulse, blood pressures, oxygen saturation, and the radiological examination of the chest through serial X-ray should be done. The complete blood count and other investigations, which I had said in the beginning, should be sent at the baseline also. Then the clinical management here is symptomatic treatment with antipyretics like paracetamol for fever, pain. For the cough, you can use antitussives. Again, maintain hydration, monitor for saturation. If required, start on oxygen. The target is to keep the SpO2 between 92 to 96%. And if the patient has COPD, then we keep it at a little less, that is between 88 to 92. Otherwise, they will not do well with high oxygen. The CO2 levels will vary with them. The initial device chosen for administering oxygen usually is the nasal prong. If with nasal prong, if the patient is not maintaining the saturation and you have to increase the amount of oxygen supplied to the patient, then you go for the simple face mask, because with nasal prong you can give good oxygen delivery up to 3 liters only. And then the simple face mask or mask which is non-rebreathing reservoir bags, that is NRBM, and it all depends upon the severity of hypoxia and the work of breathing. And with that also, if the patient is not maintaining the saturation, then we go to HFNC, that is high flow nasal cannula, which can give you FiO2 up to 80 to 100%. And most of the patients can be managed well on HFNC. HFNC, in fact, will prevent the patient most of the times to go on ventis. Then anticoagulation is a very important part of management. So prophylactic doses of unfractionated heparin, that is UHF, or low molecular weight heparin is to be given. We usually use low molecular weight heparin, that is enoxaparin, that is in the dose of 0.5 milligram per kg per weight per day, or you can use fondaparinux also. There should be no contraindication or high risk of bleeding, like if the patient has bleeding disorders, if the platelets are very, very low, if the patient is already bleeding, then you cannot use low molecular weight heparin. And in some cases, in those renal patients and all, you prefer giving unfractionated heparin, like end-stage renal disease patients. But you may even give low molecular weight heparin, but with reduced doses. Fondaparinux is also better in ESRD patients. Then anti-inflammatory or immunomodulatory therapy, steroids. which forms the mainstay. But that you can give either dexa or methylprednisolone. Dexamethasone is the most studied. Methylprednisolone can also be used in the doses of zero point 0.5 to 1 milligram per kg, or dexamethasone, which is equivalent to methylprednisolone in the dose of zero point 0.1 to zero point 0.2 milligram, which is equivalent to 0.5 to 1 milligram of methylprednisolone, usually given for the duration of 5 to 10 days. Then you have to review the duration of administration as per the clinical response. And later on, if required, patients may be initiated or switched to oral route if they are stable and or improving. But better to restrict use of steroids for up to 10 days. Don't unnecessarily prolong if the patient does not really require it. Then antibiotics are not routinely required unless there is superadded bacterial infection. Do not use antibiotics because COVID is a viral illness. So few patients with COVID-19 develop secondary bacterial infection. In those patients, you can consider empiric antibiotic therapy as per your local antibiogram. Then again, awake proning, like patient should be encouraged to keep on changing the postures if they are not maintaining the saturation, and monitor for the mental status of the patient if they are able to self prone or not, and monitor for the hemodynamic instability also. Coming to the management of severe cases, again, early supportive therapy and monitoring, symptomatic therapy, of course, with paracetamol for, and if the patient is not responding, NSAIDs, naproxen can be used, antitussives for the cough, maintain euvolemia. Use conservative fluid management in patients with severe COVID when there is no evidence of shock, because we don't want to overload the patient with IV fluids, because that will act to the load on the lungs, and that will cause further problems in breathing for the patient. So respiratory support, give supplemental oxygen therapy immediately to patients with severe COVID and respiratory distress, hypoxemia or shock. We can start with oxygen, as I've said, from 3 to 5 liters and titrate depending on the SpO2. In non-pregnant people, nowadays we prefer keeping SpO2 above 90 because of shortage of the oxygen. But in pregnant adults, we keep between 92 to 96. Then NIV, HFNC, if they are not maintaining with the nasal prongs, with the mask, then, and if you need more oxygen, then you have to change the mode of delivery of oxygen. Intubation should be prioritized in patients who have high work of breathing, and if they are not tolerating NIV, or if there is a presence of hemodynamic instability or altered mental status or multi-organ failure, then you go to put invasive ventilator, use invasive ventilator on them, intubate and put on ventilator. Then use conventional ARDS net protocol for ventilatory management. Use contact precautions when handling the contaminated oxygen intersurfaces of patients. So you have to manage these patients, of course, in PPs, and all the protocols should be properly followed. Otherwise, you can anytime get infected if you are handling these patients without proper precautions. Then anti-inflammatory or immunomodulatory therapy, again like methylprednisolone or dexamethasone in the same dose, like methylprednisolone 1 to 2 milligram per kg IV in two divided doses, or dexamethasone 0.2 to 0.4 milligram per kg OD for 5 to 10 days. And anticoagulation, low molecular weight heparins later on can be switched to oral anticoagulants. But if the patient is not moderate or severe, in mild cases, or even in some of the moderate cases, you can even start with apixaban upfront without even giving low molecular weight heparin. That can be used. It's in the protocol. So weight-based intermediate dose of prophylactic unfractionated heparin or low molecular weight heparin, as I've said, 0.5 milligram per kg. If the patient is obese, morbidly obese, then you have to increase the dose if there are no contraindications or no risk of bleeding. An end-stage renal disease patient, you have to reduce the dose. So depending on the patient, it is case to case, you have to decide on the dose of anticoagulants. Monitor serially the X-rays. HRCT should not be done that frequently unless the patient is worsening. Monitor for CRPs and D-dimers every 24 to 48 hours if the patient is serious. Every day you have to do CBC, LFT, RFT, and even IL-6 can be done to see for the deterioration. So management of hypoxemic respiratory failure in ARDS patient, like if the patient have increased work of breathing or hypoxemia, even when oxygen is delivered with a face mask, then you have to go to high flow nasal cannula, which is a non-invasive mechanical ventilation, and that can deliver oxygen of up to 80 liters to 100 liters. And if the patient is maintaining saturation above 94 with HFNC, then good. If the patient is not maintaining even with HFNC, then you have to ventilate the patient. So endotracheal intubation should be performed by trained and experienced provider, because we don't want people to keep on trying, because this aerosol will get generated and other people and the one who is intubating can also get infected. So it should be performed by trained and experienced person with all airborne precautions. Then patients with ARDS, especially those who are obese or pregnant, may desaturate quickly during intubation. So they should be pre-oxygenated with 100% of FiO2 for 5 minutes with a face mask or a reservoir bag and or an IV, and then with the expert should be intubated. Then implement mechanical ventilation using lower tidal volumes, lower inspiratory pressures. Tidal volume we usually keep between 4 to 6, and that's a job of an intensivist actually. Use of deep sedation may be required to control the respiratory rate. If the patient is not cooperating, then you may have to sedate. Okay, then this is all to be adjusted in the ICU, like how the tidal volume have to be adjusted is done by an intensivist in the ICU. Then coming to the management of septic shock, we have to recognize the septic shock in adults when infection is suspected or confirmed and vasopressors are needed to maintain the mean arterial pressure. We should maintain mean arterial pressure of more than 65 and lactates of more than 2 in the absence of hypovolemic or septic shock. And two of the three of the following, like altered mental status, tachycardia or bradycardia, means heart rate less than 90 or more than 160, and in infants heart rate less than 70 or more than 180 with prolonged capillary refill, and they are tachypneic, there are rashes on the body, increased lactate level, if the urine output is falling, if they are hypothermic, they have to be very closely monitored and managed accordingly with the help of intensivist or the physician. So resuscitation now from septic shock in adults, we have to start with crystalloids. Initially, crystalloids means ringer lactate or normal saline. So give 30 ml per kg in adults in the first 3 hours. Now in resuscitation from septic shock in children in well-resourced setting, we give 20 ml per kg. And we can give up to 60 ml per kg in the first hour. And do not use gelatins or starches or hypotonic crystalloids. You use normal saline or ringer lactate. So determine the need for additional fluid boluses also. So normally we give 250 to 1000 ml in adults or 10 to 20 milligram per kg in children based on the clinical response and the improvement of the perfusion targets. If the perfusion targets, that is MAP of more than 65, urine output should be more than 0.5 ml per kg per hour in adults or 1 ml per kg per hour in children. Then see for the skin signs, level of consciousness, and then you have to decide on next how much volume of fluid needs to be infused. Consider dynamic indices of volume responsiveness to guide the volume administration beyond initial resuscitation, because it actually, that's what I've said, that we do not want to overload the patient, but we do not want the patient to be underhydrated as well. So you need to monitor the hydration status of the patient. So administer vasopressors when the fluid resuscitation does not work and the shock persists. So the central venous catheters, if they are not available, ideally you should put in a central line. Even if the patient is in hypotension, you should put in an arterial line. But if that is not available, you can start vasopressors through the peripheral line through a large vein. But you have to monitor for extravasation and signs of local tissue necrosis, because if extravasation happens, you have to stop infusion and change the line. But till the central line is put, you can start the patient on peripheral line and start giving vasopressors to bring their blood pressure up. Now, this is just a slide on convalescent plasma therapy. Convalescent plasma therapy is not new. It was used previously in SARS. But for COVID-19 now, it has been said that convalescent plasma therapy has no role. It does not either affect mortality or hospital stay. Only some papers are there which say that if you give convalescent plasma in initial first 3 days, then only the mortality can be reduced from 11% to 8.5%. Nowadays, all corporate tertiary hospitals have stopped using, all good institutions are not using convalescent plasma therapy. We hear giving plasma therapy only in the nursing homes these days, but no tertiary hospital now uses convalescent plasma therapy. So this is about the pregnancy, like how to manage these patients, like if they have traveled to an affected country where there has been a number of cases are more, or they have come in close contact with COVID-19 patient, then you have to send for RT-PCR. And RT-PCR should be from two sides, that is the nasopharyngeal as well as the oropharyngeal swab. Maximum positivity is from the nasopharyngeal swab, that is 70%. If you do only oropharyngeal swab, the sense positivity rate is only 30%. And in some places I had seen people taking only oropharyngeal swab, not the nasopharyngeal swab. In that case, you can miss out on number of patients, and these patients will then infected people nearby and to the society. So if they are asymptomatic, and if there are no isolation rooms, you still have to monitor them till the report comes. So you can ask them to use double mask at home, monitor the respiratory symptoms and signs, monitor for the temperature and oxygen saturation. If the test comes negative, then there is no need to monitor these patients further. But if the test comes positive, then these patients have to be quarantined for 14 days, that is isolation at home if they meet the home isolation criteria. And then it has to be managed by the obstetricians. Now if the patient are symptomatic, if the fever is more than 38 and they have respiratory symptoms, then these patients should be monitored in the hospital. They should be kept in an isolated room, preferably with negative pressure, and they should be monitored with full protective gear for visitors, health personnel, and delivery and neonatal procedure equipment on site by the obstetrician. If the SARS-CoV-2 comes negative, then they should be isolated at home if they are in a position or in a non-COVID ward, if the symptoms persist. And if they are SARS-CoV-2 positive, then you have to monitor, you have to keep them in the hospital, start the treatment as per protocol, monitor their heart rate, blood pressure. Chest imaging can be done in pregnancy also if required with the abdominal shield. Even a CT scan can be done in pregnancy for COVID-19 if required with abdominal shield. And then the fetal heart rate maturation has to be checked by, that has to be managed by an obstetrician, that betamethasone is given for fetal maturation, IV antibiotic depending on the local protocol if required. If the patient is in the intensive care, then you have to monitor the systolic blood pressure, the mean arterial pressure, the respiratory rate, see for the Glasgow Coma scale, whether the patient is conscious or not conscious, see for the severe failure criteria, whether the patient is in septic shock, whether there is acute organ failure, whether there is fetal distress, and delivery that will be as per the obstetrician. So, like women should be advised for the antenatal follow-ups and OPD. The women who is pregnant should be advised to attend routine antenatal care, but tailored to minimum. Like the number of visits needs to be cut down because it's a risk for the patient coming to the hospital in these COVID days. So it should be at the discretion of the maternal care provider. Usually they say you can be called at 12, 20, 28, and 36 weeks of gestation unless they meet the current self-isolation criteria. The obstetrician will decide. Rest of the time, they can do digital consultations. Now, for women who have had symptoms, the appointments can be deferred until 7 days after the start of symptoms. Unless symptoms like persistent cough become severe, then of course you have to call the patient to the hospital and examine with full PPE. So if needed to visit health center, they should take own transport or call an ambulance. For women who are self quarantined because someone in their household has possible symptoms of COVID, the appointment should be deferred for 14 days if the patient is stable. then any woman who has a routine appointment delayed for more than 3 weeks should be contacted by the care provider. And even if a woman has previously tested negative for COVID-19, if she presents with symptoms, again, COVID-19 should be suspected and RT-PCR should be repeated. Referral to antenatal ultrasound services for fetal growth surveillance is recommended after 14 days following the resolution of acute illness. So, prevention, but anytime, is always better than cure. You have to take all the precautions in case you don't want to get infected. So, wash your hands regularly with soap and water, 20 seconds each time. Proper protocol of hand washing needs to be followed. No handshake, no close contacts. Cover your mouth and nose when coughing or sneezing. Follow respiratory etiquettes. Avoid direct contact with live animals at markets and consume only thoroughly cooked food, meat, and eggs. So avoid close contact also when you are experiencing fever and cold or flu-like symptoms. You should isolate yourself if you are symptomatic till all the reports comes and you become asymptomatic. Avoid spitting in the public because if you're positive, then again you can transmit the infection. Seek medical care if you have fever, cough, and difficulty in breathing. So this is all from my side. Thank you so much.
Thank you, ma'am. Thank you very much. It
Thank
was
you.
so beautifully you have explained the treatment, and so
Yeah.
detailed explanation has been given, ma'am. It
Thank
was a
you.
wonderful presentation.
Thank you
Thank
so
you very
much.
much.
Thank
There
you.
are 2-3 questions, ma'am. If you allow me, then I'll read those
Surely.
questions. The first question is about
Yes, please.
ivermectin.
You can go
Yeah,
ahead, please.
yeah. So why ivermectin is used randomly in COVID patients when it is known for parasitic worm infections? So that's the first question.
No, yes. Yeah, ivermectin is an anthelmintic. We had been using it for ages, but then initially, when the COVID wave started, some of them said that it improves and clears the virus. It helps for viral clearance in 48 hours. You can clear the virus by about 70%. That was what thought so. Like it was thought so in the initial stages when COVID
Right.
management had started. And then there are some papers also published, but they are all anecdotal. They said that using ivermectin helps in the clearance of the viral load and also in the symptomatic improvement. That is why we had been using. Now, recently, just yesterday, I had read somewhere because now most of the bodies said that ivermectin is of no use. So also with hydroxychloroquine. So someone actually has challenged the ICMR and even the WHO, saying that when it has been shown to be a good drug, it helps for clearance of the viral load and even for the symptomatic improvement. Just because it is a drug which is cheap and easily available, we all are not encouraging it to be used. We don't know. There are controversies all throughout. So I really don't know. But initially they used to say that it's a good drug for viral clearance. Now they're saying that it has no role, but it is still there. In the guidelines, it is still there. You can use it with doxycycline. So everything is still controversial for COVID except for oxygen, steroids, and anticoagulants. Rest of it is all controversial. Like remdesivir, actually, if you see, we have seen about 10,000 patients of COVID. We actually see very good improvement with remdesivir. But then when there was shortage of remdesivir, now it has been removed from most of the bodies. Like they say it's of no use, it doesn't affect mortality. But then we have found it to be really useful in improving on the symptoms and reducing the length of hospital stay. Because staying in the hospital, you can otherwise catch up other infections also.
Correct.
So I find it to be a good drug. But then see, it is too early to comment on all these because it's only 1.5 years that we have been managing COVID. It will take some time. See, even for the vaccines, now vaccine also, I wanted to put in a slide actually, everyone should get vaccinated. But again, like for any other illness, vaccines are not made as early as has been done for COVID within a record
Yes.
period of less than a year. Otherwise, it takes so many years, minimum 10 years for a vaccine to come up. So this also, so there are controversies for that as well. So we
Correct.
really don't know. Let's see. Yeah.
Yes, ma'am. Thank you.
Yeah.
As you rightly said about opportunistic infection, there are a lot of papers about mucormycosis and
Yes.
zinc. Ma'am, your opinion about it? Is it
Yeah.
true or is it all
No,
controversy?
no. We are seeing lots of cases. In the first wave, we have not seen so many cases of mucormycosis. In the
Hmm.
second wave, we had been seeing more serious patients coming in, more patients who require oxygen. And as it is in COVID, the diabetes control goes for a toss because the
Right,
virus enters the body through ACE receptors, and ACE receptors are present everywhere in the body, even in the pancreas. That is
right.
why the sugar control goes haywire. And this time we are really finding we have about 7 to 8 patients of mucormycosis admitted in a hospital, whom we have done even surgeries and given the medication. So it is really there, but then it could be because of either, that's why I had said initially that judicious use of steroids, that is
Hmm.
one. Proper control of diabetes, because as it is in COVID, diabetes control goes for a toss. So if you have to give insulin to those patients, monitor the sugars properly, keep the sugars under control. Then those who are immunocompromised, those who require oxygen. And this second wave, we have found patients coming with hypoxia, most of them requiring oxygen. So with the humidifier, if the water is not changed, they say
Hmm.
either you should use a non-water based this thing apparatus, or you
Sterile
have to
water.
sterile water or
Hmm.
saline. And then there was shortage of oxygen, so industrial oxygen was being used. So that also is not as pure as the oxygen
Medical
used for
oxygen.
medical oxygen. Yeah,
Yeah.
that's what. So all this and those with other comorbidities, they are all prone for the infections actually. Those who are neutropenic, and in viral infections, you get neutropenia. So we are really seeing these patients with mucormycosis. That is why judicious use of whatever medicines you give, proper monitoring, keeping the parameters under control is very important if you don't want your patient to land up in these with mucormycosis infection.
Right, ma'am. And the
Mm.
last question is, ma'am, you are also measuring interleukin 6. So apart from immunomodulators, any treatment typically directing interleukin 6? Is there any guidance?
Yeah, see, interleukin 6 is also not a very reliable test again. And
Okay.
OPD basis, we do not do interleukin 6. We do it only for admitted patients. Initially, the recommendation was to start immunomodulators, that is monoclonal antibodies or steroids, when IL-6 are more than 5 times the normal. But nowadays, they say you can still wait. You can start it when it is more than 75 times the baseline.
Oh,
So,
okay.
but yeah, but then if we have seen, like immunomodulators, again, we have used tocilizumab for so many patients, even itolizumab when toci was not available, bevacizumab we are using, because again, toci was not available in between. And now you have to, then in such patients, there are chances of secondary bacterial infections also. So then
Yes.
in those cases, when that time we monitor the PCTs also, and then give them appropriate antibiotics if required, if there are suspicions of secondary bacterial infection. But OC and all also, initially in the first wave, many people used to use tocilizumab for 2 times also. They used to repeat it. But then what was found is even after giving tocilizumab, the incidence of fungal infection increases. So
Hmm.
nowadays we don't use it more than once, if at all we use. We are not using tocilizumab that much these days. If you treat the patient properly right from the beginning, most of them do not go into cytokine storm. Only
Right.
thing is you to monitor the patient properly and accordingly treat it.
Right, ma'am. So
Yeah.
thank you very much. It was an eye opener for us.
Thank you
Amazing
so much.
presentation and amazing session, ma'am. Thank you. Thank
Thank
you
you
very
so
much for
much.
all your
Thank
support.
you. Thank you
Thank
so
you, ma'am.
much. It was nice meeting you all digitally. That's right. Yeah.
Thank you.
Thank you. Thanks a lot. Bye. Good day. Yeah.
Yes, wish you the same,
Yeah.
ma'am.
Yeah. Yeah.